think this may be applied to CHF too. If you go below 3,000 milligrams or lower, you stimulate the renin-angiotensin system.
That's the thinking of why the heart failure
right.
data didn't pan out.
That's right. There was that, and so in hypertension too, I thought for hypertension somewhere the sweet number is 3 to 5 grams, and divide this by 2.5, that would be sodium. So we're actually, you know, I belong to the group who's the happy medium. Is I rather go a little higher. I think the 2,300 is too strict.
Yeah, I would agree with that. And look, nobody's dying of sodium insufficiency in the United States, right? So I just tell people, don't use a salt shaker, and don't go and drink 10 glasses of water a day, but just eat and drink what you want.
And the number one source in the U.S. by CDC is bread as the source of salt, by the way.
Yeah.
Way ahead of pickles and all the other things you think are high. So, and then dining out, the number one source is pizza. I mean, a full-size pizza usually is 10 to 12 grams. And the second largest at home is cheese. So bread and cheese and pizza are going out. These are the three big ones.
Fortunately, wine has no salt in it.
So in the calendar, I said under beta blockers, I said achieve a heart rate of less than 70, and Rich says closer to 60.
Yeah.
And I have patients who, let's say, are in atrial fibrillation, so we cannot use Corlinor. And I've put patients on up to 50 milligrams of carvedilol BID and started them on metoprolol succinate. And I get calls from the pharmacist that this cardiologist of yours is crazy.
Yeah. So first of all, let me address that. You're absolutely right. The numbers that I gave you are only for trials in heart failure. We do not know what the ideal heart rate is in atrial fibrillation, although it would make sense.
Yeah.
The problem is in AFib is that if your average rate is 60, that means some of the time it's going to be 30 or 40. And so we tend, in our heart failure clinic, we shoot an AFib for a heart rate of 80 to allow wiggle room for the 2.5-second pauses that everybody's going to have.
No, I'm talking about heart failure patients.
Right, but that's what I'm saying about heart failure. So in a systolic heart failure patient in AFib, we're going to allow their heart rate to be 80 in atrial fibrillation. In sinus rhythm, we're going to try very hard to get it to 60. Now, for carvedilol, even though most people think the dose is 25 twice a day, that's only people up to 170 pounds. And so in America, for a lot of places, like in Oklahoma probably, the normal dose would be, or maybe Homa, the normal dose would be 37.5 twice a day or 50 twice a day. Titrate to the heart rate. Okay? Now, there are also, unlike most things we deal with, the beta receptor has more genetic differences. In this audience, 15% of you have a mutated beta receptor, and hence you're not going to have the normal heart rate response. Everybody here knows that because there's some people you give 12.5 milligrams of metoprolol, and their heart rate's 48. Right? That isn't because they hyperabsorb the drug, it's because they have a different polymorphism. And hence, this is a natural experiment in biology. You have to go up to the dose, and once they hit 60, you stop at that dose. So I don't target the target dose, I target the heart rate. And as you just said, some people are going to need a higher dose than what is the target, and some may in fact warrant 2 beta blockers, which is, you got to get on the line because the pharmacist is going to say you're crazy, but it's true.
So a question from the audience is, how old are the studies saying that salt and water restriction do not work? And if so, what are the names of those aforementioned studies?
Yeah. The analysis that I just showed is 6 months old. The trials, the randomized trials, were done around 2006, 2007, so about 10 years ago. But because they fly in the face of dogma, they didn't get a lot of press.
Next question, is treating renal artery stenosis with renal artery stenting beneficial?
Well, I think, after we did the years of what I call drive-by angioplasty of the renal arteries, when you found to have them narrowed, I think basically you have to look at your eGFR. So from a hemodynamic standpoint, you can have 80% or 90% stenosis be normotensive. Then you get somebody who has probably only 70 or 70%, 75% stenosis and has hypertension. So basically, if you have high-grade stenosis and you're well controlled on medications, which would be an ACE inhibitor or an ARB, a statin, LDL's got to be 70 at the worst. And the aspirin, that's the standard dose. There were now 4 trials. The last big one was called CORAL. And basically, bottom line is that the outcome of angioplasty with stenting was identical to medical therapy, or so So when do you do renal artery stenosis repairs? I think you look at the eGFRs. If you lose more than 5 ml per year of kidney function, which is called rapidly progressive loss of renal function, you should start looking for repair. If you got high-grade bilateral stenosis, particularly if you have flash pulmonary edema or you have a heck of a time controlling your CHF. So I think you have to have a reason to refractory hypertension. So then you should start looking. But if you have someone with 75 or 80% stenosis, eGFR is stable, lose 1% or 1.5 per year, and your blood pressure is well controlled, you have no business, quotes unquote, to do angioplasties.
Thank you. And can chronic iron deficiency without anemia cause heart failure in the absence of any other identifiable cause?
I won't say it causes heart failure, but the trial that I showed you, there are now 3 trials using fusions, and we give it in the office. But all 3 of those excluded anemic patients. So this isn't driving up the hemoglobin because of iron deficiency anemia. These are people who have hemoglobins. They may be a little low because of chronic disease, right? So they come to you, their hemoglobin is 12, but they have an iron saturation of 5% and a ferritin of 27, okay? Those people, we now give iron infusions. It usually takes between 4 and 8 iron infusions. We drive their ferritin up to 250. And if you do that, their EF goes up and they feel better, do better, by every metric that you can measure in the heart. So this is a heart, not a bone marrow treatment.
And could you address or point to fact about postpartum cardiomyopathy and its treatment?
Yeah. So, anybody that has otherwise unexplained dilated cardiomyopathy, either at the very end or very soon after delivery, end of a pregnancy or right after, is labeled as having peripartum cardiomyopathy. Now, it turns out that if you either biopsy those people or you do genotyping on them, some of them actually are genetic idiopathic diabetic cardiomyopathy that only presented during pregnancy. So I think that's a little different group. The people that have truly unexplained peripartum cardiomyopathy, half of them, and we don't understand why they get it, half completely normalize in every measure that you can measure. The other half have some residual dysfunction. Some, they never get better, their EF is still 25. But the majority either get better and they're at 45 or 50, or they're just normal. Now, unfortunately, subsequent pregnancies can have this recur about half the time. So we normally recommend that they not get pregnant again.
And if the ejection fraction improves and they're clinically stable, do you cut back on the drugs?
Yeah, we don't know the answer to that. So what most people will do, of all the drugs that we use, the most important are beta blockers. And so our normal would be to say if somebody truly has normalized, whether it's peripartum cardiomyopathy, and I'm not talking Takotsubo, but some form of cardiomyopathy and they're now better, we will perhaps, and they're not hypertensive, then we'll remove maybe the renin-angiotensin modulators. We tend to leave them on beta blockers. And there is this healed heart failure group. It's sort of a new category. Those people remain at higher risk than people who never had cardiomyopathy. Perfect example, I have a guy in the hospital right now. I saw him yesterday. He had 50 shocks from his defibrillator. He had an EF of 15. His EF is now 50, but he developed an SBO, small bowel obstruction, and had 50 shocks from his defibrillator. His ejection fraction probably now lower. I don't know. But, so once you have cardiomyopathy, you have scar in the heart, and you're not totally normal. So I wouldn't think that we should say, stop everything and drink champagne.
And then can you elaborate on the non-invasive testing for amyloidosis?
Yeah, so there are many. Remember, amyloidosis is a grab bag, meaning you have deposition of abnormal proteins in the heart. These are misfolded proteins. In older people, by far the most common is transthyretin, which is the normal protein that all of us have, that is the protein that circulates around to transport other molecules, including thyroid hormone, etc. So it turns out that transthyretin in some people misfolds, and that misfolding clogs up the heart and is toxic to the heart muscle. And that's detectable using a technetium bone scan. It's the same exact thing you would do a bone scan for, except you don't look at the bone, you look at the heart. And if the heart lights up, bingo, the person has transthyretin amyloidosis. Okay? So that's the standard test for that. We used to do biopsies. I haven't done one now in several years. The other main form, especially in younger people, would be a leukemia-like variant where they're overproducing an immunoglobulin, either kappa or lambda, in 80 or 90% of the people. That's determinable by a blood test. So with a nuclear scan and a blood test, usually you can avoid biopsying. And that means biopsying of anything, the skin, the fat pad, the rectum, the tongue, the heart. We just do blood tests and scans now.
Just if you have low levels of kappa or lambda light chains, they may only be in the urine.
Yeah, you can.
So I always feel, look, I'm feeling better from a renal standpoint by doing 24-hour urines because
For renal amyloidosis.
That's right, renal amyloid. So sometimes, and that's actually equally cheap to do it from the urine.
Right. And the reason to look, by the way, is it used to be we said, who cares because they're all going to die, right? That used to be the attitude. The kappa lambda now responds to chemotherapy. So if you pick it up soon enough and you knock out the clone that's making the abnormal light chain, they get better. And there have been now cases, I don't know about the renal literature, but in the heart, where the heart actually gets better.
Well, renal-wise too, I think I think we call it plasma cell dyscrasia because it's like a holdback, like you said. It could be multiple myelomas, it could be just light chain disease alone, and it could be amyloidosis. So it's a whole group.
Yeah, and if you have somebody with MGUS who now for some reason presented with heart failure, recheck their levels because all of a sudden the clone could have taken off and now they have amyloidosis.
The question is, if the blood pressure is naturally 90/60 millimeters of mercury without any intervention, question mark, I suppose the question is asking somebody whose blood pressure is 90 systolic and has heart failure.
Yeah.
I think it also brings up the question about patients who are hypotensive on meds in the hospital and nurses holding the meds because the patient's blood pressure is low.
Those are called calls every day to me. It's totally misplaced. So first of all, if you look at the average blood pressure of somebody walking into my heart failure clinic, it's about 102. Okay, so they're no longer hypertensive. One cure for hypertension is an EF of 20%. It cures them all. Cures them all. So they all have, and there are a few that still have high blood pressure. They're kind of really vasoconstricted, but most people do not. So we accept glibly systolics down to 85. Once they start getting down to 80, we get nervous. And I mean, I've had people call me from home saying my blood pressure is 68/40. Okay, well, that person, you better back down on the medicines. But if they come in, they walk into the office, they're feeling fine, they're playing golf, and their blood pressure is 88/60, terrific. Stay on your medicines, and I'll see you next visit. So I do not hold, and the most important to hold are the beta blockers. Now, most people don't, and this is a discussion I've had with our nurses at the hospital. So here's the hypothetical. You have a bunch of systolic heart failure patients who have low blood pressure. You give half placebo and you give half metoprolol. Which group ends up with the lower blood pressure? It's the placebo group. Unlike hypertension, in which beta blockers lower pressure, in fact, in the heart failure population, blood pressure goes up 3 points compared to the placebo group. So holding the beta blocker makes no sense unless they're bradycardic. Then it makes sense.
One other aspect is I think people, especially maybe not recently, but in the past, were over-diuresed.
Yeah.
So you have actually volume depletion.
Well, there's no question, and particularly with Entresto, I mean, when you have potent vasodilators, if somebody comes, if somebody walks into your office, their BUN's 90, their creatinine is 2, they're on 3 diuretics, they're bone dry, and their blood pressure is 90, right? That would not be a person where you'd glibly increase the vasodilators. What you would do is back down on the diuretics because they're clearly pre-renal induced iatrogenically by maybe appropriate diuretics. But what happens a lot of times is people start getting better, the heart's working better, and nobody reduces the dose of their diuretics, and now they're suddenly volume depleted.
Questions?
Yeah. So the role of MRI, I didn't talk about imaging, but what has really changed our decision making in recent years has been technology, and that's true both in the echo world with speckle tracking, strain rate imaging, and in MRI specifically looking for gadolinium enhancement. And so, for example, in our clinic, no matter how low your ejection fraction is, if you have non-ischemic dilated cardiomyopathy and you have an MRI with no gadolinium enhancement, we don't put a defibrillator in. Those people do not benefit from a defibrillator. If you have an EF of 40 and you have lots of scarring, you get a defibrillator. And that's because the substrate for ventricular tachycardia is scar formation, which is readily identifiable using MR. And the other benefit of MR and PET and other methodologies is you can help determine. There are people who come to me who, we didn't know it, they have sarcoidosis, or whatever, right? So there are some that are treatable in a totally different way. 10% of all the people in the US who are carried with a diagnosis of hypertrophic cardiomyopathy actually have something else. Hemochromatosis and amyloid are the most common. So those are the kinds of things you can pick up with imaging. So we do right up front a lot of these imaging modalities. Once you put a device in, it's a lot harder to image them. So we tend to do it up front when we first diagnose it. So yes, I do think that peripartum cardiomyopathy patients should have a specific cardiac MR. Yeah. Yeah, so for hypertrophic cardiomyopathy, the preferred treatment is surgical myomectomy rather than alcohol, ethanol septal ablation. It's safer and better. However, we tend to try to, so my oldest hypertroph right now is 98. She has a stroke volume of about 12 cc's. You can only walk from here to there, but I mean, she made it to 98. Both her kids have hypertrophic cardiomyopathy as well. So there are people that, you look at their echo and you go, you got to be kidding, but they can be functional, right, and do okay. So we reserve myomectomy for people who are really at the far end of the spectrum of hypertrophic cardiomyopathy.
Dr. Fuentes.
Supplements in Santa Monica? Never heard. Copper, I have no idea,
No, but basically all the heavy metals, the definition of a poison is its concentration, if you think about it. So
Yeah.
all the heavy, from iron to hemochromatosis to copper, all of them in high doses are toxic.
Well, for sure iron is, and the only trace elements that I know in the heart failure world, iron's one. The second is actually the toxic effects of amyloid protein. It turns out if you have muscle cells and you put in amyloid protein, the muscles start misworking. So it's not just a structural thing. And the other is selenium deficiency, which in certain parts of the world, and particularly in China, cause dilated cardiomyopathy due to selenium deficiency. I'm not aware that that's a big issue in America, but I don't know about copper.
So the question is 10 METs. How does she explain?
10 METs?
That's
your
great
muscles
exercise,
ache.
Tom.
Yeah, that's your breathless and your muscles are aching.
Yeah, that's 700 watts plus. That's a heck of an exercise.
Yeah.
10 watts.
I mean, on a treadmill, that's like going 5 miles an hour at 16% grade or something like that.
It's a huge amount of exercise.
My average patient in my heart failure clinic is 82 years old, so they can't do 10 METs, frankly. But what we just, and cardiac rehab, of course, is now approved for heart failure because exercise is an important component to make people more functional. It does not make the heart better, but it makes everything else better. Right? So we tell people to walk. That's what and for lots of other reasons in the geriatric population as well. But I think 10 METs in that population is unrealistic.
And the second part was exercise versus? Diet versus exercise.
Yeah, and it was said earlier that fitness trumps fatness, and I believe that. So I think that exercise is more useful. Now, 10 minutes 3 times a week, honestly, is probably not enough, especially in the old people who aren't. Yeah, but that was 10 minutes of interval training, 2 minutes, 2 minutes, 2 minutes, 2 minutes, and the old folks can't do that. So for those people, we tell them to walk 20 to 30 minutes every day.
We have some time.
Yeah, so the question is, because low ejection fraction heart failure patients are prone to sudden death, and that's a true statement, if somebody has the newly diagnosed, let me put it that way, newly diagnosed systolic heart failure, what do you do because they're still vulnerable for sudden death? True statement. And you're right, the reason there's a blanking period, the first reason was because the acute MI data showed that if somebody has an acute infarct, let's say an anterior MI, and their EF's low, and you put in a defibrillator the next day, that doesn't help them, it turns out. And the reason is because a lot of those people actually will have improvement in their ejection fraction over the next 6 to 12 weeks. So we currently recommend 12 weeks of data because that's the healing time of the heart. And putting people on appropriate therapy, a dramatic number of them will have EFs that rise above the range that you would normally be tempted to put a defibrillator in. Now, what's changed the equation is the recent randomized trial on which I based my statement a minute ago, that if people have no scarring, we don't put a defibrillator in no matter what their ejection fraction is. Because in the randomized trial, if you had non-ischemic dilated cardiomyopathy without gadolinium scarring, you did not do better with a defibrillator in place. You've just wasted $35,000, and you've also made the person at risk for lead infection and, you know, perforation and other things. So that's kind of a fork in the road. So we do not currently recommend for everybody, especially the non-ischemics. We don't put life vests on them. The ischemics, you could argue maybe that's the right thing to do for the first 42 days or however long period of time. And that's kind of a societal decision just because of an expense issue. Very few people, but the sudden death rate, so if you have a class 2 heart failure patient, the sudden death rate right now in the U.S. is about 4% per year. So if you do the math, in the next 3 months, the risk is less than 1%. I would argue the risk of putting a defibrillator in is greater than 1%. No, it's actually contraindicated for heart failure.
The question is external counterpulsation for heart failure patients, ECP.
Yeah, and remember that's the indication for that is angina. Yeah, no.
No, she's talking about patients with chronic angina and a reduced ejection
Also
fraction.
have, yeah, I mean, so it doesn't help the heart. I mean, I guess you could argue it reduces edema, in a perverse way, but it's not indicated or meant for heart failure. Now, if you have a person who has both diagnoses, yes, you can use it for angina relief if they've not had appropriate relief with conventional treatments.
Yes, please.
Mm-hmm. It's actually more complicated than that. So, yes, we definitely, when you reduce the heart rate, you improve diastolic filling time. So therefore, there is more filling, which makes the next beat a little better. That's true. However, you also reprogram the genes of the heart so that the heart actually changes the myofilament contraction. So you alter the genetic expression by giving beta blockers. So it's more than just heart rate reduction per se.
Any other questions? All right, before we take a break, let me, we were talking about nurses and blood pressure. So